Good morning.
Good morning.
Good morning.
Just wait a brief while. In-service go well, Tulsi? Bet you're glad to be done.
Yeah, exactly. It was okay.
Great.
Some good stuff. Yeah.
Hopefully some of the EP looked familiar. That's always the hope. All right, why don't we get going here this morning? Okay. So this is I don't know, can you see the top of the screen here? I think you can. So this is an implantable loop recorder recording, and the device recorded this presumably because of these pauses. So, and you could see that this occurred at 1:39 a.m. So I guess my question to you is, do you agree that this is, has this loop recorder identified the problem? So why don't we ask Molly, what do you think about this? I think, Molly, you just went on mute.
Sorry, I just got on because I had to hop on and off because my audio was not working.
No problem. So I was just saying that this is an implantable loop recorder from a 14-year-old with unexplained syncope. And this is the tracing. Do you agree that this is, you see that the computer is measuring the R-to-R interval in milliseconds.
Uh-huh.
Do you agree with this greater than 2 second, these two greater than 2 second reports, which would obviously warrant a recording?
The strip in the middle, you can almost still, if you're marching out where you're seeing at the beginning of the strip, you can still almost see little teeny deflections. So I don't know if just the recorder's not picking it up. Yeah, you can still see it march out, and it looks like it's marching out somewhat similarly.
Yeah, I agree with you.
And the top looks like that too, I think, but not as quite apparent. I think the middle strip looks clearer to see.
This is where having calipers, right, would be useful.
Yeah.
But yeah, I think that this is some form of artifact. So the way ILRs work, as you know, is that the device is inserted under the subcutaneous area, typically leftward of the sternum. And most of these devices have a battery that's at least 2 years, sometimes even longer. And typically what we do is we program the device to record whatever we really want it to record, whether it's too slow of a heart rate. So you might say heart rate's below 45, record, and you might say heart rate's above 165, record. And the system will record it, and then through the magic of remote monitoring, which is what this tracing is, we can see whatever alarms the device recorded, whatever it thought was abnormal. And this was one of the tracings that the device sent through. But actually, I think you would agree that this is most likely a form of artifact. And I don't know exactly why this is happening. But you notice that it's happening at 1:30 in the morning. So presumably it has something to do with the position of the patient lying down. Maybe lying makes the signal less good. Remember that we basically put it in everybody the same way, subcutaneously, and hope that it's going to give us a good vector. But it's not always the case. And then in certain positions, perhaps it moves a little under the skin and doesn't make as good a recording. So this is, in this particular patient, Josie sends me at least one of these every couple of months from the same patient. There seems to be something about the position of this device that causes this to happen, but this is not actually a true pause. So, okay. Right, this is a a tracing that was sent to me from my friend, Dr. Savli, all the way on the other side of the planet in Cambodia. And this is what he described to me as a 32-week gestation patient who is, this is day of life 1. And he wanted to know what I thought the diagnosis here was, and also how should we treat it. So why don't we see, Sergey, do you have any thoughts on this tracing? It's a somewhat difficult tracing.
Good morning.
Good morning.
Yeah, that's an interesting tracing. So I'm trying to identify the rhythm.
It's always a good place to start.
So I'm just going to talk through what I see. I see that the rhythm is irregular. I feel that there are several morphologies of the QRS. Some of them are narrow and some of them are wide. And it seems like that I would probably say that this is premature atrial contractions with aberration. My first choice would be. Because I see so that there are some kind of small deflections that could be just a different morphology P wave, and they're coming early. The only thing is that when I look in the middle, let's say, of almost in the middle of this tracing, and there's this, there's this run of 1, 2, 3, 4, 5 kind of whitish QRSs that might look like it's a VT, but then again, there are some deflections before most of this complexes.
Yes.
That again tell me that's probably it's premature atrial contractions with aberration.
I agree. I mean, when you it would be sort of bad luck, right, to have I think we would agree that there is a fast atrial rate, right? It's some of these P to P intervals are as fast as 300 beats per minute. So we would expect that there might be some aberration associated with such a fast atrial rate. And although it's conceivable that that could be VT, it seems unlikely, right, that somebody would have both VT and an atrial tachycardia of some sort. So I agree that that is probably aberration, varying degrees of aberration. So what do you think this rhythm is? Is it just... It is PACs, so formally you're right, but is there a name we can give to this rhythm, you think?
Of course, it's so since I don't see any flutter waves, I would say that it's an ectopic atrial tachycardia.
I mean, I think that's probably what this is. It's possible it could be flutter, right? It could, flutter waves. When you say you don't see flutter waves, you mean you don't see like a sawtooth pattern? Is that what you mean?
Yes.
Right, but you don't have to necessarily see that, right? You could have flutters that have different morphologies and all. And this is hard on a PowerPoint. But I think in your mind's eye, you could imagine this P to P interval is not exactly fixed. It's actually a little bit longer here and a tiny bit shorter here, and it's varying a little bit. But this is an area where there may even be 2-to-1 conduction, possibly. So I think probably this is an ectopic atrial tachycardia. I would have to take out calipers in order to see for sure. It's possibly flutter. Certainly the atrial rate is a little slow for flutter in a newborn, right? What would the atrial rate normally be in atrial flutter in a 32-week gestation child who's only a day of life?
Well, it probably will be faster than 300, 400.
Yeah, it would be 400 or 500 beats per minute usually. right? Normal SVTs like ORT or AVNRT in a baby this age would be close to 300 beats per minute. But atrial flutters, usually we would see 2 to 1 or 3 to 1 with a ventricular response rate of like 200 and an atrial rate of like 400. So this atrial rate, although fast, is actually not fast enough, I think, to call this flutter, at least not wouldn't be a usual form of flutter. So I think this is some form of EAT. And I call it EAT rather than chaotic atrial rhythm, because I think most of the P waves that we see look kind of similar to one another. So I think it is probably just one focus. So, all right, Sergey, let's make up a scenario. You're, for example, at Bronx Care on call one night, and you see this patient, and how would you manage this? What would be some of your options? There's no right answer, but there are a couple of wrong ones. So what are some options?
I guess one of the right options would be amiodarone.
Right, you could give amiodarone. That's certainly possible. And how would you dose that?
Amio, I would probably load with 10 by kilo per day, and then give maintenance at half of that dose. And I will give it slowly, not to cause any hemodynamic instability.
So I agree with you. You would for a few days give 10 per kilo per day, because right, SVTs we normally treat with 5 per kilo per day, and the load is usually 10 per kilo per day. But how do we normally start it? So would you just start it at 10 per kilo per day, or would you is there even a faster bolus that you give to start? So most people would give 5 per kilo. Typically, if you read PALS, I think it's like over 20 minutes, but we would not normally do that in a baby who's otherwise stable hemodynamically. So I would give that very, very slowly, probably give 5 per kilo over 2 or 3 hours. And then I would start a continuous drip of 10 milligrams per kilogram per day, just as you said, in order to load the child. And then once stable, you could switch to 5 per kilo per day. And what would you do, Sergey, if you saw a cardiovascular collapse associated with your bolus or your load?
I would give fluids. I would give boluses of fluids.
Mm-hmm.
To
of course, you'd stop the amiodarone.
And stop the amiodarone.
Right? Some people have described giving calcium in that setting, inotropic support. Some people, unfortunately, even need ECMO support. It can be that disabling. So one needs to be very careful. And how would you administer this? Through what kind of a line, typically?
You mean the amiodarone?
Yeah, if you had your perfect choice, what would you use to deliver the amio in the 32-week gestation baby who's basically a newborn?
You mean peripheral versus central line?
Yeah.
I guess central line would be better.
Why is that? I mean, okay, we know any medicine, right, has a better chance
Right.
of getting in centrally, but is there anything particular to amio that would make you more concerned about it being given centrally?
Yeah, I think it's about the fact that it can leak some toxins from the plastic. Is that right?
Well, I mean, that is true about amio, but that's true whether you give it centrally or peripherally, right? You're right. So what you're saying is that amio can leak toxins from plastic tubing, and that has been implicated as a potential danger of that medicine. That's true. So sometimes people say you should use glass tubing or some other form, but that could be you could deliver it through a different kind of tubing either way. But that's a true statement, but not germane to how you would give it in terms of where you would give it, rather. Any other thoughts?
Yeah. Another thought would be because of the possibility of causing phlebitis when you give
Right.
amiodarone through a peripheral IV.
Yeah, it's very, very sclerosing. Amio, will cause phlebitis and very bad can cause very bad chemical burns. I've seen this many, many times with amio. Really want to try your best. In an emergency, of course, you give it peripherally because if it's an emergency, it's an emergency. But you really would want to try to get it centrally as soon as the patient is stable. Because if you have no option for central administration, then you really need to monitor that IV extremely carefully, like Q1 hour checks, because and then what invariably happens is that patient is the one who needs IV peripheral calcium, which of course is very sclerosing as well, dangerous to give peripherally. So you would want like a UV or a CVL or a PICC line in a perfect world to administer amiodarone to a newborn or a very young infant. Okay, so that's one option. But let's say, Sergey, that you're at this theoretical hospital, and they say, we don't carry amiodarone in our formulary for babies. So any other options?
I guess another version would be flecainide.
Right, you could give flecainide. Flecainide would be a very good agent in general for this type of arrhythmia, right? We see that, but that is an enteral agent, but definitely that in fact was one of my recommendations to Dr. Savli, was that he should consider that. Any other options?
Would sotalol be another option?
Yeah, sotalol is an excellent option. Oftentimes one needs to go at very high dose in order for it to be effective for this type of arrhythmia. And in fact, we now have IV sotalol called Sotalize. That's the brand name and the only form that it comes in right now because it's not yet a generic agent. So we could give IV sotalol and there have not been reports of hypotension associated with IV sotalol, so that the use of that agent might potentially avoid the hemodynamic compromise that we see in patients who get amiodarone IV. Any other IV agents that we could use?
How about procainamide?
Yeah, we could use procainamide. A lot of places that would be their first agent. Procainamide is a reasonable agent. And then, of course, you could also try oral amiodarone, right? Enteral amiodarone as well, depending upon how stable or unstable the patient is. I mean, we're looking here at a rate of 158. We would not expect that would cause a lot of hemodynamic instability in a newborn. So one could make a strong argument that if you wanted to use amio, you could just give it enterally rather than IV if you want to try to avoid the potential dangers of intravenous amiodarone in a small infant. I think that would be not unreasonable. I'll just point out that, look how the ECG interpretation is so abnormal, it's so wrong, right? It says atrial fibrillation, which it's basing on the irregularity of the rhythm. It's saying that the patient's having unsustained VT, which I think we all agree is not true. And finally, it's saying the patient has LVH by voltage. That might possibly be true in a newborn. Have to calculate it out. But the bottom line is, you can't really go by the interpretation of the computer, unfortunately. Anyway, thank you, Dr. Savli, for showing me this tracing.
One question, Dr. Bass.
Of course, Tarek, sure.
Yeah, so like when given the amio 5 per kilo over 2 hours, would you recommend during that time preemptively just bolus in the calcium too, or not?
It's not a bad idea. I guess I've not heard of people doing that. That might be a reasonable option. It reminds me of how when we've been doing these piccolos, Dr. Sham from Memphis says that every time before he's about to insert the Piccolo device, he gives a dose of IV calcium, which he believes makes the patient more stable. So I guess sort of a analogous for an entirely different reason. I don't know if that would make a difference. I believe that it is thought that there is an alcohol base that it comes in that can cause an idiosyncratic reaction. And I'm not really sure if giving calcium would prevent it. And I would be marginally concerned that if it was given peripherally, that it might cause chemical burns. So I would generally probably would not do that. I think the most important thing is when you have a very small infant, in my view, you have to be very careful with IV amnio. And I would say that, if you are an intensivist as you are, Tarek, and you're going to be taking care of children for the next 30, 40 years, especially in NICUs who have complex heart problems, you really want to try to avoid IV amnio if you don't have to use it. I'm not suggesting it's not a great agent, and it is terrific, and it saved the lives of many, many, many children, including many patients of mine. But it definitely, if you use it enough, you will see that happen. And most of the fellows, I think, have seen that happen already in one or two of our patients. It's not a concern out of the infancy period, but especially in the newborn period, it is a definite concern. And in fact, in the only randomized controlled trial of IV amnio, which I am like the 87th author on that paper, it showed something like a 30% serious adverse event rate with the use of IV amiodarone. So I would be very cautious with that agent. Again, I don't want to frighten you away from it. There are times where it's absolutely necessary, but on the other hand, if there are other agents, for example, procainamide, that might be similarly effective, you might want to think about trying that first. For example, the group in Boston pretty much uses proc as their first line for almost all arrhythmias that require IV parenteral therapy, because if it's given in small little boluses, it's not associated with cardiovascular collapse. It can cause hypotension, but if it's given in a small enough bolus of, like, say, 5 per kilo over a half hour to an hour, it's unusual to have significant hypotension. And that is a type of hypotension that will almost always respond to volume, as opposed to the hypotension associated with this idiosyncratic reaction to IV amnio, which sometimes does not respond to volume. So any other questions, Tarek, or anybody else?
No. Thank you, Dr.
I have one question about the amnio. Like, if someone's starting to have, like, let's say you're not at the full, like, collapse version, like, stage of it, but if you're starting to see hypotension, is there benefit to slowing that initial infusion, or is it like once you're seeing signs of it, then like
I think I would say that once you're seeing signs of it, you probably should stop. I mean, it's okay to see a very minor degree of change in blood pressure, right? That happens naturally, but if you think there's any version of a trend in the first half hour to hour that you're using it, honestly, I would stop it. And that's one of the reasons why I suggest giving it like over 2 to 3 hours. I'm not really sure that makes a difference, to be honest with you, but I kind of feel like if you're giving it slower, maybe you'll identify the problem sooner and stop it before it becomes more of a problem. I'm not really sure if that's ever been demonstrated to be true, but that's been my general approach. Now, obviously, somebody is resting in front of you. You just push the amnio just as it's suggested in PALS. I would again, I don't want to say it's not a reasonable agent. It's perfectly reasonable, but one has to be very cautious with it. And I would argue that people who use it very, very frequently or very liberally probably have not encountered this. When it happens, when you get the cardiovascular collapse, it's very, very upsetting. I mean, it literally is an ECMO event, which, as you know, is suboptimal in any patient.
Sorry, Dr. Pass. Last question, I promise.
Sure.
So if this happens, you would not use amnio again after you've corrected this hemodynamic kind of collapse. You choose a different.
I mean, I would consider using it enterally, but I would not use it IV, no. Now, if somebody already were on ECMO, then it wouldn't necessarily be wrong to continue it, I guess, since you're supporting the person. But truthfully, I would not, because obviously, from the moment you go on ECMO, the clock is ticking to get off ECMO. And so the last thing I would want to do is give an agent that that potentially could be impairing my ability to detach or remove from ECMO. So I would say, no, I probably wouldn't use amio then if that happened. I mean, as we've discussed, there are many, many alternatives to amiodarone. There are times, though, where it's the only agent that works. And so it is truly life-saving. And when I started my career, IV amio was just coming into market. So it's a relatively new agent as an IV medicine. It's been around for oral use since the early 1970s. It was actually, I believe it was introduced either as an antihypertensive agent or an afterload reduction agent. And it was sort of discovered that it seemed to reduce arrhythmias, and then work was done on determining why that is. And now, of course, it's used exclusively as an antiarrhythmic agent, but it was, interestingly, was not introduced to the market as an antiarrhythmic agent. So, okay. All right, so here I am doing a pacemaker threshold test. This is an RV pacemaker threshold test. And so just so we're all on the same page, you guys know that when we in the office say we're checking a threshold, what the computer that communicates with the pacemaker will either decrement the voltage, the output of the pacemaker, or the pulse width, which is, as we've discussed many times, the length of time, the number of milliseconds that it's delivering the energy. So the standard way, usually, that most electrophysiologists do is to fix the pulse width and drop the voltage. And you can tell the computer how many pulses you want to give for each voltage as it drops down, and it does it in a standard fashion. And so if I have somebody who I am very, very worried about the threshold, I'll sometimes give like maybe 5 or 8 beats, because I want to be certain that I'm not making a mistake in determination of the threshold. But most of the time, I think the default on the computer is 3 beats. So in the right-hand panel here, I'm doing a threshold test, and we are fixing the pulse width at 0.4 milliseconds, which is a standard internal permanent pacemaker pulse width that one would normally pace with, and it is dropping the output progressively. And we see here that on this tracing here is the permanent program is 2 volts at 0.4 milliseconds. So you notice here that every couple of beats, it's dropping the voltage from 1.25. Hold on one moment, I'm sorry. 1.25, then 1.0, then 0.75, then 0.5. So my question to you is, so the device thinks that the threshold is telling us that the threshold is 0.5 volts at 0.4 milliseconds. We see here that it's here's where 0.5 volts, where it changes. Each one of these is marking when it changes. Do you agree that this is the threshold? And secondly, do you agree that this is a reasonable permanent pacing program? So why don't we turn to our friend Tarek?
Yes, Dr. Bass. So I think looking at the tracing when the threshold is dropping, see. Yeah, it does look that it changed. So I think it's still, we still have capture.
Okay. Now I wasn't clear. So this is the electrogram in the ventricle. Okay, so these two here, they're just different ways of recording it. So what happens over here when we go to 0.5 to the electrogram?
Oh, yeah, so we lost it actually. It's the last one, yeah.
So what
So
would
we
you say
lost-
the threshold is?
Yeah, so I think it's 0.5, yeah, it's accurate.
Well, at 0.5, right? So we lose capture here, right? At 0.5.
Yeah.
0.75, all three beats are capturing. At 0.5, we capture on the first, capture on the second, and we lose it on the third. So we would really say that the threshold is 0.75. In other words, the threshold is the last voltage where one has 100% capture. Okay, so
Yeah.
actually the computer is marginally off. The threshold would be 0.75.
Okay.
Hold on just one second, guys. Dr. Lamore is asking me something. Okay, sorry about that. So yeah, so we would say it's 0.75. So this actually is slightly off. The threshold is low. Anything under 1 volt would be considered a good threshold, a low threshold, but it is not 0.5. It's actually 0.75. And so the permanent setting is at 2 volts. What do you think about that? Is that a reasonable programmed output, you think?
Yeah, so I believe so. If we go with the now, we saw that 0.5 was not enough, and then 0.75 is the one we have 100% capture. So double that is like 1.5, but then we should just stay at 2.
Right. So as we've discussed, usually for most patients, we would not set the output at less than 2 volts, even if the threshold were 1/4 of a volt. Usually 2 volts is the lowest we'll set. Occasionally you'll see me program a pacemaker at 1.75. Usually I'll only do that on an atrial lead if the patient isn't using it very often. And the reason for that is that turns out that pacing at lower than 2 volts doesn't really give the patient a very substantial battery benefit in terms of longevity. That's a very small benefit. And remember that out of the box, the system is programmed to pace at 3.5 volts and 0.5. So to pace continuously at 2 volts and 0.4 is obviously a very substantial reduction, and hopefully will result in an improvement in longevity of the device. So yeah, so we would say the threshold in this case is a little higher than 0.5. We'd say it's 0.75, and we would say that the permanent pacing program is reasonable and probably leave it alone. And I think with that, we're going to stop because I'm getting a few texts from the cath lab. I hope everybody found this of some benefit, and I hope you all have a great day. Thanks for joining today.
Thank you, Dr. Bass.
Thanks,
Thank
everyone.
you.
Thank you.
Thank you.